Good afternoon. Today I'll be talking to you about an important topic which is squint. Squint is also called strabismus. The word strabismus usually indicates that we're talking about patients with deviated eyes. Strabismus is the other word to indicate squint. The class today is squint is by itself a little complicated topic, and today I'll be giving you a very basic outline, a bird's eye view, and we'll talk about details subsequently as we move further with specific topics in squint. Today we'll be discussing on the terminologies, the definitions, the classification and the symptoms. The anatomy is one important facet of squint. We need to know that the lateral and medial walls of the orbit, the lateral and medial walls, so it's a cone-like structure. The lateral, the center, the medial wall is straight and the lateral wall is a little sloping. So this forms an angle of about 45 degrees. So this houses a lot of the entire structures within it, and based on this 45 degrees of angle, we have muscles that interplay within this. So these are the important terminologies that we need to know when we are dealing with any patient with squint for both the examination and for us to be able to establish a good diagnosis and to plan treatment. So when you say orthophoria, we are talking about perfect ocular alignment. That means perfect ocular alignment. That means when the patient is looking straight, the eyes are in perfect alignment and the central reflexes, it is centered. So when you throw a light, when you elicit a Hirschberg's test, when you throw a light onto the patient's eyes, both eyes in the center, you will see the perfectly aligned reflex. So in other words, if this is the patient's eye, so you are going to see a central reflex in both eyes when you throw a torchlight. Okay, so this is the Hirschberg's reflex, which is eliciting orthophoria. Now the next important term is heterophoria. So heterophoria means when there is a deviation of the eyes when fusion is blocked. Normally the eyes will remain straight due to a fusion mechanism. So there is no obvious squint. But when this fusion mechanism is broken, then the patient will start showing us a squint. So that means the squint which was always there has been a latent and which comes out at certain areas when the fusion is broken and there is a decompensation. This phoria can be it can be an exophoria when the eyes deviate out, or it can be an esophoria when the eyes deviate in. So heterotropia means it's a manifest squint. That means the eyes are misaligned at all points. At any given time when you examine the patient, there is a misalignment of the eyes. So this misalignment of the eyes indicate that there is a failure of binocular fusion. This failure of binocular fusion is the cause for the manifest squint all the time. Again, this can be exotropia when the eyes are deviated outward, and it can be esotropia when the eyes are deviated inward. So this is the most important difference between heterophoria and heterotropia. Now next we come to two other important words, visual axis and anatomical axis. Visual axis means it passes from the fovea, this axis passes from the fovea to the point of fixation. So this point of fixation is the object. The object of whatever the object of regard is, this point of fixation indicates that the axis travels, this axis travels across the fovea to the point of fixation. We call it a visual axis. That means this is the axis through which vision is enabled. Whereas anatomical axis means it is passing from the posterior pole, okay, to the center of the cornea, There's a cornea. So it passes from the posterior pole to the center of the cornea through the nodal point. Now this is important because why are we bothering about these two words, visual axis and anatomical axis? Because these two, the visual axis and the anatomical axis, will form what you call an angle kappa. Angle kappa. This angle kappa is normally about 5 degrees. So we should know that the macula, or the central part of our eye, the central part of fixation in the eye, is slightly temporal. It is not exactly in the center of the eye. So our axis is slightly deviated, and since the macula is slightly temporal, you have this angle being formed. So when the macula is slightly more deviated temporally, then the angle kappa will become larger. And when the macula is moved slightly nasally, the angle kappa becomes a negative angle kappa or a positive angle kappa.